Welcome everybody. Today Jachinte from Lebanon will present us some data and up-to-date on SGLT2 inhibitors, also following the publication that we did a couple of months ago with Jachinte as a first name, if I remember well.
Yes.
So this is a topic that you love. So please.
And quite interesting too. Okay.
Yeah.
Let's go.
Nice picture.
Yes. Okay, so let's start. So SGLT2 inhibitors. Okay. So for today's lesson, the synopsis will be as it follows. So we're going to start first by a small overview and a mechanism of action of how SGLT2 inhibitors basically work. But first, it is important to mention that initially SGLT2 inhibitors were used for diabetic patients. However, with ongoing trials, research, etc., it became obvious that SGLT2 inhibitors were also extremely important for heart failure patients and for cardiovascular outcomes, whether we're talking about diabetic patients and non-diabetic patients, and we will dig into that further on as we go. So overall, we have 6 types of SGLT transporters. However, we're going to focus on SGLT2 inhibitors because they tackle the substrate here, which is glucose. Let me put the laser. I'll try to find it. Okay, yeah, there we go. So because we tackle glucose in this case, as I said before, diabetic patients, they used to take SGLT2 inhibitors. And all of the rests aren't really that important. However, they aren't important in our case. However, SGLT2, SGLT1 transporters were established that they were important at some point only in 10%, because 90% of the SGLT2 used to work on a big portion of the proximal convoluted tubules, whereas only 10% on a very small portion of the convoluted tubules, proximal convoluted tubules. And so if we want to start first by physiologically speaking. So basically in a normal human body, glucose is absorbed at the level of the proximal convoluted tubules and then thrown back into the capillaries. However, in the case of diabetic patients, there is a problem where we have a huge amount of glucose being reabsorbed into the blood, causing the hyperglycemic state. In the case of SGLT2 inhibitors, they just block this, if you want to say this, GLUT2 transporters, just like that, and they will cause a cascade of events just like that. And so they will prevent, therefore, the reabsorption of glucose. They will excrete the glucose in the urine, also known as glycosuria, and thereby leading to a reduction of the blood level glucose. So why is it important to dig into how SGLT2 inhibitors work in the body? Because we're going to arrive to something very important, which is the heart. And so first of all, they work by constricting the afferent arteriole, just right here at the level of the kidneys, and thereby they will induce a state of diuresis, natriuresis, glycosuria, and a low proteinuria. And all of that is so important because it will affect the preload and the afterload by, decreasing the blood pressure. So glucosuria will act as an osmotic diuretic. It will induce dehydration, and it will induce, therefore, a lower blood pressure. This is extremely important, especially in cases of heart failure, because mainly heart failure is most of the time a problem of preload and afterload, etc. So whenever we can work on that, well, we can fix the problem. And so it also works on something very important, which is ketosis. And so we know that glucose is a...
Sorry to interrupt, Jachinte.
Yeah.
2 points. First of all, theoretically, they can lower blood pressure, but practically, you will show us when you will discuss about the studies if this has a systemic effect or not as compared to placebo. And the second thing is that I think that you shouldn't use the word dehydration, because this is a sort of, movement
pathological
movement of water from the extracellular to the vascular bed and then again into the kidney and losing. So I wouldn't use the word dehydration for this effect of SGLT2 inhibitors.
Okay, I understand. Okay. All right, so as I was saying, SGLT2 inhibitors also they favor the presence of ketosis in the body by the increase of beta hydroxybutyrate, which is a ketone body. Ketosis will thereby increase the ATP consumption of the heart, and well, it will give the heart the energy needed to do its job. So why is it so important to mention the heart in in these terms? Well, because many studies showed that a reverse remodeling is associated with lower morbidity and mortality among patients who did take SGLT2 inhibitors. And following in the following slides, we will see trials that backed up this, if I must say, hypothesis, which is not much of a hypothesis really. So I'm going to start first by this randomized controlled trial for dapagliflozin that showed that whenever we used this dapagliflozin, which is an SGLT2 inhibitor, there was a reduction in the left ventricular mass in patients with type 2 diabetes mellitus and left ventricular hypertrophy. And thereby, there is a reduction in the blood pressure, the body weight, visceral fat, insulin resistance, and also high sensitivity CRP, which is a marker for inflammation. Next study, which is the empatropism, also a very important study that showed really similar outcomes with empagliflozin 2. There was an increase in the left ventricular and diastolic and systolic volume, a peak in O2 consumption, but also an increase in left ventricular ejection fraction. Lastly, we have the DM heart failure trial that showed a decrease in left ventricular and diastolic volume index and a decrease in N-terminal pro-B type natriuretic peptide. So what makes SGLT2 inhibitors that, if I must say, prominent among all of the other drugs that we used to use in diabetic patients? Well, a study from the American Diabetes Association showed that SGLT2 inhibitors were the only class among all of the others that had heart failure and cardiovascular benefits. Next up, I'm going to talk about the management of heart failure in diabetes mellitus patients and also non-diabetic patients. And we're going to see further on through the trials that I'm going to show that it became quite obvious that SGLT2 inhibitors isn't just for diabetics. It's not that selective for diabetics. Anyone with heart failure can take SGLT2 inhibitors. And we're going to see also that regardless of some parameters, such as ejection fraction, such as heart failure, or many others, there are positive outcomes. You're going to see that now. So I focused mainly on 3 different trials. So we've got the EMPA-REG outcome, CANVAS, and the Declare to Me 58. So here I'm trying to compare, or the study is trying to compare the difference between a group of patients that had already established cardiovascular disease and another sample, which, well, they had only multiple risk factors. And so only patients with established cardiovascular disease showed mortality benefit, whereas the 2 samples, meaning the atherosclerotic cardiovascular disease patients and the patients with multiple risk factors, well, they showed both of them a reduction in heart failure hospitalization. Here is about patients with previous heart failure or ongoing heart failure, well, or no history whatsoever. Here, the results are actually equivalent, meaning that the sample right here, the sample that had a history of heart failure, well, they had the same results. They both showed a heart failure hospitalization benefit to the sample that had no history whatsoever of heart failure. Here in the EMPA-REG trial, I wanted to highlight, as you can see here in red, that regardless of the HbA1c level or the glycemic control, there was survival and heart failure hospitalization benefits among the 2 samples. Also here in this study, regardless of ejection fraction, as I said before, so there are many parameters, and regardless of these parameters, we still see survival benefits in heart failure, reduced ejection fraction, and heart failure hospitalization benefits. So this is a very nice slide showing a summary of all of the results of some prominent trials. And here I wanted to showcase to you this heart failure hospitalization, that in each study we do realize that there is a decrease, a significant decrease too, in the heart failure hospitalization in these 4 studies. Okay, so now we're going to talk about the heart failure management in diabetics and non-diabetics patients. So here in this define a heart failure trial, 38, as you can see here, it's quite prominent, 38% of the participants, here it was 263 participants, 38% of them were non-diabetic. However, we do see that regardless of the diabetes mellitus status, there is a significant improvement in the KCCQ questionnaire, and a decrease in the NT-proBNP, the natriuretic peptide. Also, this meta-analysis that actually showcased 2 important trials, which were the EMPEROR Reduce, as you can see right here, and the DAPA heart failure. It showcased that regardless of any existing atherosclerotic cardiovascular disease or any history of heart failure whatsoever for that matter, there was a reduction of hospitalization for heart failure and the progression of renal disease. So I wanted to here just mention that while also SGLT2 inhibitors, they show a very important and prominent nephroprotective outcomes. However, I did not mention that in that lesson, but I'm just mentioning it right now very fast. Okay, so as I said here, regardless of any existing atherosclerotic cardiovascular disease, but also regardless of the diabetic status, and also regardless of the HbA1c level. So there are many parameters who did not directly affect the outcomes, the positive outcomes of SGLT2 inhibitors on heart failure hospitalization. Okay. Well, what about now heart failure in preserved ejection fraction? Because we did talk a lot about reduced. So there is one trial actually quite nice that showcased that regardless of the presence or absence of diabetes, we go back to the same fact again, we did see a reduced combined risk of cardiovascular death or hospitalization in patients with HFpEF. Now, what about acute heart failure? And I do like this study a lot. It's a randomized controlled trial. 80 patients were recruited. Empagliflozin was the drug that was administered, 10 milligrams, and we've got the placebo. And as you can see here, quite a prominent percentage, 67% were non-diabetic. And as a result, it's true that there were no really significant change in whether we're talking about dyspnea, weight, the natriuretic peptide, but there was a very rigid, significant decrease in the heart failure worsening, and also the heart failure hospitalization, and also death at 60 days.
Yeah, but what is this? It's a composite endpoint for the study?
Yes, that's the result.
It's
yes.
Yeah, it's an 80 patient study. So, you know, it's debatable. It's do you have this study to show the slides, to show the paper at least?
I think I do. Maybe I do. Do I at the end or no?
Yeah, because I adapt that in this 80 patient study, this was the primary endpoint. So okay. The primary endpoint, you should describe which is the primary endpoint of the study, and then describe other endpoints that came significant, like this one. Maybe we have to discuss if this was a play of chance or not.
Okay.
So we need to have more information for this study.
Okay. Okay. I'll check that out. Okay. Also, a significant increase in the cumulative urinary output with a more negative balance.
What is this study? No, come back. You have to stay on single slides. So what is this? Is the same study? Yeah.
Yes, this is the same.
Okay.
EMPA response, acute heart failure.
Let's go to the next. Okay, so what is previous?
This is the previous one.
Describe this slide, please.
So here, we were seeing the cumulative urinary output because we were also trying to see the nephroprotective effect of the SGLT2 inhibitors. And so this is
what do you say nephroprotective effect? This is a diuretic effect, I think. If the outcome here is a cumulative urine output, this is a diuretic effect.
So it's not nephroprotective?
No, this is a diuretic effect. Maybe it can also be the nephroprotective, but it's not shown in this slide, actually.
Oh, okay. Okay. I see what you mean.
And fluid balance, okay, not significant. Not at day 4, but previously. Okay.
Do I continue?
Okay, but when you present the slide, you have to go into it. Otherwise, you should skip it.
Okay.
I think here they are showing that it acts on acute heart failure by increasing diuresis, so it acts like a diuretic.
Yeah, that's the
effect.
The effect of the drug being diuretic. Yeah, I agree.
Okay.
Yeah, and it would be nice to see how is the creatinine going in this study. Try to share the slides of this study, please.
Now, okay.
You should have in your laptop, yeah.
Okay.
Because it's a new topic. We have seen these drugs working in reduction in the heart failure with reduced ejection fraction, with preserved, but acute heart failure is something new. This is a small mechanistic study, and yeah, if you have this the paper, it would be nice to see it.
Yeah, 1 second. Okay.
This does not count into your time, don't worry.
Okay. Okay, let me share it. So stop sharing now. There we go.
Okay, this is the abstract.
Yeah, do I show the whole one, the whole paper?
Yeah, do you have the paper?
I don't think so. I'll try to search for it. 1 second.
It's free article, so you should be able to download it.
Wait.
Wiley, yes.
Okay.
So this is a general rule, a suggestion that I give to everybody. Never prepare a presentation or present slides of a paper that you have not read. So never use just the abstract, okay? Because you will skip a lot of information.
Okay. Yeah, for this one, I did use just the abstract. Okay, I'll try for another time. I'll just go through it.
Yeah.
Okay.
Okay, do you have the PDF? Just click on PDF.
Okay.
It's much better.
Yes, right here.
Yeah.
I have it. If it's not working, I can share it.
You have it? Thanks.
Okay. Do I okay.
Can you see it?
Yeah,
yes.
Thanks.
Okay.
Okay, let's go down. I don't know if there is a... Okay, so it's 80 patients. Let's go here. So assessed for eligibility, 800. So a lot of patients were excluded. Yeah, that's incredible. More than 90%. Wow. So, okay. Then allocated to empagliflozin, placebo, lost to follow-up, 1.
They didn't check the creatinine. They just checked the urine output and NT-proBNP level and the length of stay. So I don't think they compared the creatinine.
Yeah, let's go down and see how long was the follow-up. So this is the basal. Okay. No, okay, come up, please, a little bit. Okay, so we have up at the beginning of this table.
Yeah.
So we have EMPA on the left and placebo on the right. So go down. So one thing that, here, that comes, to my eyes is that despite it's not significant. NT-proBNP is 4,400 in EMPA and 6,100 in placebo. So the difference is big. So the patients, according to heart failure parameter like NT-proBNP, is much worse for the empagliflozin. This is one important point. Okay, so let's go down. What is this? Change in VAS dyspnea. Okay, this is okay. Empagliflozin placebo.
So dyspnea has decreased. Symptomatic improvement, and length of stay is the same. It's the same between the two drugs. It does not affect length of stay.
Also, proBNP did change in NT-proBNP from baseline to, so it's not changing. This is strange, but maybe it takes more time to observe the effect. The day 4 is maybe too short follow-up. Okay, let's go down.
So mainly it's a diuretic response. This one, it's significant.
Yeah. Yeah, what an important information would be also to see how much diuretics they used in each arm, how much Lasix and how much other diuretics they used here. This is important. Okay, let's go here. Clinical events. Okay, worsening heart failure, but this is, subjective. Death or heart failure readmission at day 30. So no difference. Worsening heart failure or heart failure readmission. Okay, yeah. So, this clinical endpoint is a play of chance because they are all driven by worsening heart failure, which is something very subjective. So, when you go and dig into a study, you have to face, in this case, to a very small study, 80 patients. So if they claim that there is a clinical difference, you have to dig into it. And you can see here that we have a very strange endpoint with worsening heart failure plus death or heart failure readmission. So the weight of each parameter of this composite endpoint is very different and are all driven by worsening heart failure, which is, as I said, subjective, not numbers, okay? So the value of these is very, very debatable. And the bad news is that proBNP didn't change, actually, from baseline to day 4. And this is not a great information. And the other information that we need to collect is how much diuretics they use and how is the creatinine at day 4 and at day 30.
Okay.
I don't know if we have this data below. Yeah, diuretics is used 27 times. So now let's go. Just we don't have the time to read the paper, but maybe there is another figure. So this is the one that we saw that diuretic effect is there. Let's see adverse events, but yeah, this is nothing. Yeah, nothing important. It's strange that this paper was published in European Journal of Heart Failure, but it's okay. Okay, thanks. So Jesse, please
is there
come
any
back to...
other? Is there any other papers on acute heart failure, or is this just the only one?
I'm not aware, but no, I'm not up to date with this topic actually. I have to admit.
Okay. So I'll go back to my
please.
slides.
So in the meantime, Amit, you are with the primary PCI or what? He's not listening to us. Okay. So yeah, let's start again from this one.
Okay. So soloist WHF trial. What is that? Okay. So here they try to establish the effect of sotagliflozin on also the heart failure. So here they raised this question that in patients with diabetes and recently worsening heart failure, does this drug, sotagliflozin, decrease CV mortality, heart failure, urgent visits, and heart failure hospitalization? One second, let's just put my laser. Okay.
Yeah, the point here is that this drug seems to act also as SGLT1 inhibitor, not only as SGLT2 inhibitor.
Exactly, right here. And so out of all of these patients, 1,222, they came up with this conclusion right here, is that in patients with diabetes with worsening heart failure, this drug, sotagliflozin, it significantly decreased the CV death, the heart failure urgent visits, and also the heart failure hospitalizations.
All of them, composite endpoint.
Yeah.
And no difference in death. That is 11 and 13% cardiovascular death, actually. So again, reduction in worsening of heart failure, which can be, what does it mean? Heart failure, urgent visit versus hospitalization. They are, two similar patterns. So here in this composite endpoint, they count twice, but it's, the same thing, which means that the heart failure is getting worse for this patient. Here counts two.
I have a question. Does this mean that we're going from a compensated heart failure to a decompensated, or both of them are decompensated?
No, they are both decompensated. At some time, this number of patients get worse. And it seems that this drug is protecting them from this worsening without having an effect on cardiovascular death out of 1,200 patients. But I would, if I was the reviewer of this trial, publishing the New England Journal of Medicine, I would have pointed out that the primary endpoint is a little bit debatable for aiming at this journal.
Oh, I didn't understand this remark.
So I said that this is a co-primary endpoint, a sum of heart failure with urgent visits and heart failure hospitalization, which mean the same thing. One patient can, So there are two items pointing at the same point, plus cardiovascular death. So this is a debatable primary endpoint.
So these two would just be, they would fuse them together and it would be the same.
Yeah, but maybe also, I don't know if they adjudicated it in a hierarchical way or not, or in a temporal way. We should understand that reading the paper, or if they counted it twice.
Okay.
This is something that I don't know because I should read the paper.
Yeah, okay. Okay, so that I think already said that. Just small point that was a decrease by 33% in the composite primary endpoint right here.
Yeah, this we have already seen there. Yeah. It's the same information. Yeah.
Just here one thing, that the benefit of this was persistent regardless of the ejection fraction. However, there were small limitations to that study. For example, it was a small number of preserved ejection fraction, so we wouldn't be able to really assess that. And it really ended early because of the funding issues and stuff. So.
And which was the planned population for this study?
Excuse me?
Which was the planned population for this study? How many patients did they want to enroll? So when you don't have to respond now, but when you see that the study was interrupted before the end of the study, you should understand why, the reason, and which was the goal population and which was the percent of population actually enrolled. So this is very important. Because the primary endpoint is constructed according to the goal population. If you don't reach it, everything comes difficult to say.
Okay, I understand. Okay, thank you. Okay, so now up onto the adverse effects. So just like every single drug present in the market, there are some adverse effects for SGLT2 inhibitors. However, the favorable effects kind of outweigh the unfavorable ones. Besides, the unfavorable effects weren't that much significant in the literature. For example, very rare cases of fractures, very rare cases of amputations. Only amputations were seen, especially among diabetic patients, because it's quite present there. And
did any study show an increase in amputation with this drug as compared to placebo?
I didn't look into it.
This is very important because how can you claim amputation? Increase in amputation for you in your opinion. Okay, let's say this drug showed in some study an increase in amputation. So, in your opinion, since this drug is reducing the glycemia, which is the possible cause for increasing amputation with this drug?
Okay, I see. Mm.
So you have to pose this question to you. Hypotension, yes, it's. I don't remember having seen any of this, severe hypotension with this drug in any trial, but you are more up to date than me, so you should look into it. Diabetic ketoacidosis, so how many patients in each study as compared to placebo? The same for fractures, same for urinary and genital infections. So these are unfavorable effects. What does it mean? Are they real unfavorable effects shown in the studies, or they are hypothetical unfavorable effects?
Yeah, I see. Okay. And should I also look into, for example, which drug is causing the most unfavorable effect? For example, is EMPA causing more than DAPA, or is not that
You
significant?
cannot say that until you have a direct comparison, but so far I think that there is nothing, and also in the future, I doubt that you will ever see a direct comparison in an adequately powered study between each of these drugs. Okay. Look at the NOACs. Are you aware of any direct comparison? No, nobody's going to do that. So this answer, it will be difficult to respond to. Unless we know that some drug have a different effect. Maybe a sotagliflozin has also an SGLT2 inhibitor effect in the gastrointestinal tract. So maybe it can be associated to more side effects. But that said, unless you have a direct comparison, it will be very difficult to claim that.
Okay, I see. Okay, thank you. Up to our next, to our last but not least. So there is a study that looked into the possibility of a quadruple therapy, meaning the combination of SGLT2 inhibitors with MRA, beta blockers, and ARN inhibitors. And this study showed that whether we're talking about relative risk or absolute risk of all-cause mortality, both of them were increased here and here, whereas mortality was decreased. And so this opens new horizons to what we call a quadruple therapy. So a cross-analysis of that kind of combined 3 different trials, emphasis, paradigm, and the DAPA heart failure, established some sort of a comparison between the conventional therapy, this one over here, and the comprehensive disease-modifying pharmacological therapy, which is, well, the quadruple therapy. And as a result, there was an add-on of years of life, whether we're talking about at 55 years of age and also at 80 years of age. So it did show some positive outcomes, this quadruple therapy. And this is why we're opening up this new, name of the Fantastic Four. And actually, I wanted to ask you, Doctor, if you have any, opinion about this, because as I was searching for it in the literature, I couldn't really find something, significant about it. I mean, is it always done like that, or depending on guidelines?
What do you mean?
Well, do you all, as a physician, do you always prescribe SGLT2 inhibitors as a quadruple therapy, or alone, or depends?
You have to go into the guidelines, in the heart failure guidelines, and the American ones. This is an interesting point. So we should dedicate the lesson to heart failure guidelines, Europeans versus American ones. So Sarah, please take note of that. I would like to see a lesson on this. We can do, I think, an extra lesson on this, because it's a very important topic for the cardiologists. So I would say from now to mid-May, it would be nice to have this extra lesson.
It's a good point, Jachinte. I think the 4 pillars, we emphasize the 4 pillars, but not always you can introduce all 4 pillars at the same time. Sometimes you're limited by renal function. Some patients have UTI while in hospital because of catheters. So you can't introduce, we tend not to introduce the SGLT2 at that time, but then maybe in the outpatient setting. So ideally, your aim is to try and introduce all 4 of the pillars, but sometimes you can't, because blood pressure, because pulse rate, because other, patients are fasting, they're not eating as well. So you have, it's kind of just you try and introduce what you can, and then for me in heart failure, I think regular close follow-up in the outpatient setting to try and optimize the therapies to get them on the 4 pillars. Now you've got additional other therapies as well, which I think if we do a session will be quite nice. Things like iron, iron supplementation. I think there's good data for that. So there's a few other things that we can do. Non-pharmacological strategies, asking them to weigh themselves, to fluid restrict, to salt restrict.
Yeah,
So it's quite an interesting, so it's quite
Diet.
an interesting field. Yeah, so there's a lot to it. But yeah, the 4 pillars are good, but not always we can introduce.
Yeah, of course. What is crucial is to follow these patients, to start also the European guidelines that we will need to review, because I read them more than 1 year ago, are going through, they give suggestion on how to start, but then what is important is how to implement that according to the status of the patient. So the follow-up of this patient with a strict follow-up, with also possibly with the modern methodologies of monitoring these patients is very important. But we don't have to forget the importance of H inhibitors or ARB and diuretics, because from this slide, if you just give a look at this slide, you say, okay, let's give beta blockers, MRA, ARNI, and SGLT2 inhibitors, but many patients have a lot of fluids that they need to reduce. So at least at the beginning, they should go with some diuretics, and SGLT2 inhibitor will never overcome the diuretic effect of a loop diuretic, for example. It is a diuretic, but it's a mild diuretic. So it will be interesting to have this lesson, I think, very soon. You can do that, Jachinte. Do you have the time to prepare it?
I will contact the dear Sarah. I will ask her if she can provide me with the date, and I'll see. But I would be more than happy to.
You will agree.
Sure.
You will agree with the date. So you are you will be our heart failure specialist, and it's very important because we also have to deal with heart failure also, not only to coronary stenosis and all of that.
I guess for me,
we will arrange the
I guess for me, that I just wondered, Jachinte, did you read up on the Impact MI trial? Did you go through that earlier?
But
so
the
that
one
was
of
the trial that was
ACC
presented at ACC last week, and I think for us as interventionalists, that's quite interesting.
Yeah, I was so happy. Last day, a few days ago, I started removing beta blockers after 10 years of myocardial infarction.
So I think
patients
ACC
were
this
so
year
happy. So I removed beta blockers and Viagra, and contemporarily sometimes.
So I think Impact MI was the empagliflozin in the post-MI cohort, the post, kind of large MI, and actually showed, there was no improvement in terms of mortality, except you did have less heart failure exacerbations. So a bit like Paradise MI, when Entresto was, supposed to be the magic bullet, but didn't actually do much in the acute setting. So I think chronic heart failure and acute heart failure are very different. And I think I think the SGLT2s have a big role in the chronic.
Bharat, you made a great point, because this is something that we said, but we never implemented. We should keep always a lesson after the big meetings on a review of the major trials that have been presented. We should do that. We should do that. Sarah, we should prepare a lesson also on that, an extra lesson, or if you want to switch somebody that would like to be postponed. I think that within 1 month from now, we should do that before EuroPCR, because after EuroPCR, there will be another one.
Okay.
So let's remind of this after the big meetings, which are CRT, AHA, ACC, EuroPCR, ESC, and TCT. I would say, I don't know if I forgot something, we should program after 2 weeks a lesson on the big trials coming out, a discussion about that. Yeah.
Okay.
Let's do that also for the future. So congratulations, Jachinte. You did a good job. I would like to know if there are questions. I don't know if Amit is still here or he started his primary PCI. Probably he went away. Any other question for Jachinte? I see that there is a message in the chat by Rima. Yeah, as I remember, there was an increase in amputation in the Canvas trial. So this is something that we should go through, just as an open point from this presentation. Jachinte, if you can just give a fast look, without preparing a slide, next time we meet, if you can remind us how was the rate of each big and consistent complication after all of this trial, if there was a significance versus placebo with these drugs.
Okay, so the adverse effects and the trials that backs it up.
Yeah.
Okay.
The most important ones, the big ones, yeah.
Okay, sure.
Okay, fine. So if there are no other questions, I think we can close this lesson.
Okay.
Thanks a lot. I don't know, Sarah, if we have to discuss, you have to say something about the papers, Sylvia, Wojciech,
Yes,
Bharat.
so I